Do we shift the patients of ARB to ARNI? And if the patient is stable on ACE and ARNI, do we change to ARNI at all? Yes, definitely we need to make a change when a patient is on ACE or ARB. Clearly, in all these trials, it has been proven that ARNI is a superior treatment for this aspect of HFrEF, heart failure with reduced ejection fraction. So why deprive a patient of a superior treatment when it is available in the market? There is no patient who is stable today, because suppose a patient gets an event tomorrow, does he not deserve ARNI today to prevent that event? So that's the answer for this question, wherein many of the patients can have sudden cardiac death, many of them can worsen overnight, and a person who looks stable today, in the trials also it is being shown that they get repeatedly hospitalized. So if you have a patient of HFrEF who is in functional class 2 or functional class 3, he is not considered stable. There can always a possibility of something going wrong. And this is overcome by changing the patient from ACE-ARB to ARNI. ACC-AHA guidelines clearly indicate to us that if you find the patient on such a scenario, it is best option is to shift them to ARNI and maintain them of ARNI, so that the stability of the patient is maintained longer and overall outcome of this patient can be better. The initialization of ARNI should be inside a hospital when a patient is about to be discharged from the hospital. In fact, personally, I prefer the patient started on early before he is discharged, so that we know what's happening to his blood pressure, we know what's happening to his hemodynamic status before he goes home. So I would think of a person who is acutely decompensated, he is off IV diuretics now. There has been no escalation of IV diuretics in the past. Inotropes have been stopped for last 24 hours. He's been up and about, maybe sitting in a chair. This type of a person should be started on ARNI. He should be withdrawn of ACE inhibitor for 36 hours, if at all he is already on. But this is the time to start an ARNI with the best possible dose you can think of, because you can observe the patient in the hospital for some time. The Pioneer HF trial was exactly in this subset of patient, wherein when it was started, it showed that in the period of next 2 to 4 weeks, there was a dramatic improvement in the overall outcomes. Such an outcome was not possible when the patient was on ACE or ARB at the time of discharge. So the idea is very clear: acute decompensated heart failure. Once he is reasonably stable in the hospital, start with the ARNI, which is the best possible dose. Try adjust the other medication to fit ARNI into the prescription. And when the patient goes home, the first visit should be within 10 days and followed up later. So at the end of 1 month, you would offer him the best benefit that ARNI can offer by way of starting this treatment as early as possible. De novo heart failure is, shall we say, relatively benign as compared to the acute decompensated heart failure. Here the patient probably presenting for the first time, not on any previous treatment before, and because of its first episode probably carries a better prognosis or a longevity of life. Definitely he should be offered the benefit of ARNI. There have been enough number of trials, especially the transition trial, which looked at this aspect of de novo patient being started on ARNI. In the next 4 to 6 weeks, this kind of a treatment wherein significant doses were achieved showed remarkable benefit related to remodeling of the LV. The remodeling being prevented leads to better CV outcomes, less repeat hospitalization, better improvement in the NT-proBNP, and probably prevention of sudden cardiac death. Obviously then, with such a strong evidence, I have no doubts in my mind that it should be started, the ARNI should be started in all de novo heart failure patients unless it is strongly contraindicated. So a patient who is stable going home from a de novo heart failure hospitalization must be on ARNI, which are appropriate doses, and then followed up closely so that we build up the doses to the best of its advantages. When shifting a patient who is already on ACE inhibitors or ARB, ARNI definitely has some dose titrations to be done. If a person is less than 10 milligrams of ACE inhibitors per 24 hours for the previous treatment, he should be started off with 50 milligrams twice a day of ARNI. If it is more than 10, it can be started straight away with 100 milligrams twice a day. If a person is on ARB, say a valsartan of less than 160 milligrams, he can be switched on to 50 milligrams twice a day. And if more than 160 milligrams of valsartan would mean 100 milligrams twice a day. This kind of a switch, mind you, should be done especially for ACE inhibitor 36 hours after stoppage of the ACE inhibitor treatment. ARBs, there is no need to stoppage because the ARB is already included in ARNI. So that ARBs, the switch can happen straight away. For ACE inhibitor, one needs to wait for 36 hours to avoid complications related to angioedema. When such a treatment is switched on, the maximum benefits of ARNI can be offered to these patients. ARNI, as we all believe, is an important integral part of HFrEF patient, and our every endeavor should be to get the patient on to the best possible doses. Ideally, it should be 200 milligrams twice a day, but for various reasons, these doses are not achieved. And the obvious stumbling blocks are hypotension, which is the most common cause, and the second most common cause would be hyperkalemia. There would be worsening of the eGFR and rising of the creatinine levels in the first few weeks after the ARNI therapy. People are also a bit worried about the BNP levels going up, but BNP is bound to go up when you start off ARNI. So one should be checking on their NT-proBNP and not BNP for monitoring of the ARNI cases. But the other things which can lead to intolerance or lower doses is GI disturbances, but this is hardly in 1 or 2% of patients. So if we all in all see the commonest cause why a target dose is not achieved, or if the person is not tolerating ARNI, is because of a symptomatic hypotension, and the second is worsening eGFR. Hyperkalemia, of course, is a lab test which should be done when we do into follow-up. Gastrointestinal disturbances do not lead to discontinuation of the drug, but we should be aware of this. It's also been seen that the lower doses of ARNI are in fact more beneficial than the best doses of enalapril. This was a subgroup studied in the paradigm wherein 20 milligrams of enalapril could not match up with even 50 milligram twice a day of ARNI. So whatever dose you can deliver of ARNI is maximum tolerated dose, is going to bring a more benefit to the patient. So it's no point in continuing them or shifting them to ACE inhibitor just because a bigger dose is not tolerated. We are faced with situations wherein patients' blood pressure is borderline, because this is a HFrEF group of patients wherein they are known to have lower blood pressures. So despite that, if you start on ARNI and maintain ARNI with lot of clinical astute management, benefits are remarkable. In 12% of risk reduction of deaths is possible if you manage these patients on whatever little doses of ARNI is possible. So this is a kind of a jugglery that a clinician has to do, but should have a conviction that even with borderline doses of blood pressure, if we introduce ARNI, it's going to be useful for the patient. The other hypotensive parts, so for example, a frail patient, an old patient who is a dehydrated patient or loss of blood, do diuretics. If these things can be managed well, despite a borderline blood pressure of 90 to 100 millimeters of mercury, introduction of ARNI should be done. How it behaves later on, how the uptitration takes place, lot of things depends on the clinical reality. But in fact, the heart failure improves the blood pressure is also likely to improve, and up titration can be possible after 4 to 6 weeks. These situations are not uncommon, wherein the person BP is hovering on 90 or 100 systolic, and one feels the real need to administer ARNI to such an individual. Herein, some precautions and cautions have to be followed. See if there is any hypotensive agent on board. For example, loop diuretic. They are not disease-modifying drugs, they are symptom-modifying drugs. So it's possible to cut down on them. First of all, check whether the patient has adequate salt and volume in the system. Many of them are over-diuresed and they could be on the dehydrated side. And you add a ARNI to it, it can make them worse. So, adequately hydrated patient, adequate salt intake, patient who is not hypotensive because of dehydration is what we should be looking for. Cut down on the loop diuretic dose to some extent. Cut down on drugs which cause hypertension and are not disease modifying drugs. For example, nitrates could be on board, they don't modify the disease. There could be other drugs like alpha blockers taken for benign enlargement of prostate, or some drugs which are antidepressant drugs sometimes are taken without realizing that the patient is on that. So all those drugs which are causing hypertension can be managed the way they can be in the best possible way. Adequately hydrated patient, adequate salt intake of the patient, and then introduce ARNI. The situation again here is to start slow and increase the titration very gradually. Start low and go slow. If you follow this, hypotension related to ARNI management can be managed very effectively. When a CRTP is done before ARNI, is it the correct form of treatment? Primary and secondary indications of CRT and ICDs are known. If somebody has a left ventricular ejection fraction less than 35 and hasn't had any event at all, they could be offered a primary implantation of ICD is what one is thinking of, or a CRTD for that matter. But secondary is wherein somebody has had a hemodynamic collapse due to a documented ventricular tachycardia. For them, there is no question it has to be offered because it is too risky to leave them alone. But the indication is a cutoff of 35%. By introduction of ARNI, where if the LVF improves beyond 40, whether the indication of CRTP or ICD remains or not is a grey area of evidence. Some Egyptian evidence really suggests that the number of ICDs and CRTDs are going down because of the use of ARNI at the correct time. Suppose such an individual, say, comes to me with a EF of 30%, I would be inclined to give him a perfect treatment of ARNI and the full form of GDMT that is available. There is a good possibility that this person would cross the LVF of 40% and theoretically at least doesn't become a candidate for a ICD or a CRTP. So my personal choice here, because there is no clarity of data, is to introduce ARNI at this stage. The other example or the evidence that supports this theory is that there are people who have been introduced with a CRTP or CRTD and they are non-responders for various reasons. But you introduce ARNI to them, they get response after that, and probably they don't require the CRTP after that also. So I strongly believe that if you introduce ARNI at every point before a CRTP is introduced, give a fair chance to the patient unless it is very risky to wait without it. And if there is EF is still hovering around 35, CRTP would be indicated. The use of ARNI in HFpEF, heart failure with disorder. HFpEF actually is a difficult animal to deal with because the diagnosis sometimes is a problem. The pathology is such that it doesn't respond very well. It is said that coke travelers like COPD, hypertension, obesity, they start the disease outside and then it comes to the heart. Whereas HFrEF is heart itself is bad, and then it affects the systems outside. So here is a disease which probably needs to be tackled so far only by the management of comorbidities. There is no real drug which is really affecting the diastolic properties of the heart. So we give them little diuretic, little slowing of the heart, control of blood pressure, control of AF. There have been number of trials related to HFpEF, but they all have been singularly failures. The Paramount trial, which was it's a big, shall we say, an anticipation that ARNI will do very well in HFpEF, disappointed all of us because the results were not dramatic. However, there are very good sides to this Paramount trial. It improves left atrial size, which actually matters as far as atrial fibrillation is concerned. It improves NT-proBNP, which indicates the myocardial recovery and ventricular remodeling. So there are quality of life is definitely improved when the person is on ARNI for HFpEF. So there are definitely good indications related to ARNI in HFpEF, but direct mortality benefit was not seen. There would be individuals who were HFrEF to start with, and now they have climbed up with an EF of more than 45%. So there is really a grey area related to this. But Paramount also showed that up to 57% EF, one can use ARNI. So if your patient is already on ARNI, gets a better EF, don't change, that is one. If the person has a borderline EF, say about 40-45%, don't be shy of using ARNI. Because in these indications up to 57%, you would be doing justice to the patient because there is no real other drug which can improve. Empagliflozin and the SGLT2 inhibitors are making some headway towards HFpEF, but the real breakthrough is yet to come. Till such a time, I would be inclined to use ARNI in HFpEF patients and it's an excellent antihypertensive as well. And larger doses are possible to give because there are no issues of hypotension in these patients. So I would be inclined to use it till the LVEF about 50%. And the benefits related to quality of life, LS size, NT-proBNP at present appear good enough for me because there is no real other treatment available. The new FDA guidelines and the ACC/AHA gives ARNI a 2B indication for the use in HFpEF up to 57%. That means it is not contraindicated. Not that it's not going to work very well, but it is not going to give you a mortality benefit. It will help the patient definitely to some extent. So there would be an inclination towards use of that in HFpEF as well. But the contraindications actually are based on a lot of common sense. What have been the contraindications for ASARB probably continue. Somebody has a strong angioneurotic diathesis, probably one would be contraindicated, or a known hypersensitivity to ARBs, one would be reluctant to use. But the real contraindications are the eGFR less than say 25 or so. That is where definitely ARNI will be contraindicated. If the liver function is grossly distorted, mild and moderate probably you can continue, but remarkably reduced deranged LFTs, one would be thinking twice of using ARNI along with it. If pregnancies and breastfeeding, they are still not known areas, so one would not venture in there. Pregnancy, of course, it will be a complete contraindication. If somebody is on ACE inhibitor and has got angioneurotic edema, these are the patients who one would be very careful, but we can still introduce ARNI to that. So these are all contraindications, as I said, which are based on common sense. And if we keep a good vigil on this, probably we can introduce ARNI to most, and the obvious contraindications will be followed. About 18% patient develop hypotension, and drug has to be withdrawn related to ARNI. There could be worsening of GFR in about 3% patient, persistent hyperkalemia in a smaller number of patients. These can happen. Person who has a bilateral renal artery stenosis is a contraindication for ARNI. Person who is on oral contraceptive pills is a contraindication for ARNI. Lithium use also is a relative contraindication because it can increase the lithium toxicity. So these are the things which are in small letters. One has to do extra reading for understanding these contraindications. Hyperkalemia in ARNI can be of two types. One patient already has hyperkalemia, or if the person is getting hyperkalemia due to the use of ARNI. The first thing to see is whether there are any other causes of causing hyperkalemia. For somebody is taking larger dose of MRAs, or whether MRAs are indicated or not, or somebody is taking a lot of fruit juices which contain a lot of potassium. People have the habit of consuming juices like this, or there are other fresh fruit and other things which lead to there are high potassium containing foods like salads and all. So they should be restricted. In fact, introduction of a small loop diuretic would help here, because that will drive away the potassium to some extent, and you can still use ARNI despite the borderline hyperkalemia. K-bind like drugs are also available, and of course in the hospital the good old glucose insulin potassium drip can be used to combat the acute hyperkalemia. A new type of MRA is round the corner, and when it is available, I think it is going to be a routine use for the management of hyperkalemia along with ARNI. So the dictum for hyperkalemia of ARNI is we should be aware of it, we should be checking on it, we should look at the other areas like worsening EGFR, diet which contains potassium, drugs which increase hyperkalemia. And once we do that, probably finally we may have to end up reducing the dose or stopping the dose if the hyperkalemia gets very dangerous. Okay.
Yes.
Once ARNI started, can it be withdrawn if the person improves, is the question. This question almost reminds me of a question related to hypertension, that you have started an antihypertensive medication to an individual. The blood pressure is now controlled, so do we withdraw antihypertensive medication? The answer is no. You have a refractory error, you wear a spectacle, you start seeing well, so do we stop wearing it? No. Same is true, though despite the analogy, same is true of heart failure. You have managed a better heart, you have managed a better EF, you have managed a good hemodynamic situation by the use of ARNI and other drugs. So why get away, why withdraw them at all? Because you are exposing the person to again worsening, and the next time worsening doesn't respond as well as it responded for the first time. The prevention of relapse is possible by continued use of drug. The other way around, if you withdraw ARNI, it could be leading to relapse of the original situation. Hardly less than 5% patients would be having etiology which corrects on itself, like a myocarditis or acute history like a prolonged Takotsubo's cardiomyopathy. If the original etiology is improved, if we can feel that the original etiology is gone, then it's a different story. But for a larger subset of more than 95%, you have attained something fantastic by use of these drugs. Don't fritter away the advantage by withdrawal of the drugs. And the withdrawal causes should not be very simple causes. If at all you have to withdraw, there have to be real solid causes. But just because the patient has improved now, if you withdraw, you are inviting a relapse, which could be a worse situation to deal with rather than the first time what we did. Is AD, HF and de novo heart failure different? The acute decompensated heart failure, as it mentions, necessarily the patient already has a heart failure of some duration. That itself makes the patient a higher risk variety as compared to somebody who has a first episode of heart failure. The first episode can be a grave one. Despite all that, the patient doesn't have a previous history, doesn't have too many comorbidities, and doesn't carry the baggage of the previous heart failure. Also, when we think of acute decompensated heart failure, Here is a patient who is already on some treatment for heart failure, and despite that he has worsened. That means something already grave has happened to him. Such an individual obviously is not as well off, let's say less worse as compared to somebody who's de novo. De novo could be presenting first, he could not have been on medical treatment before, and there could be just risk factors like hypertension, diabetes, and presenting for the first time obviously carries a better prognosis as compared to the ADHF. And that's why ADHF is considered graver as compared to de novo heart failure.